like to share with you a project that we've got going on in the southern part of the United States. This is a project in the emergency department at a 656-bed hospital who is seeing about 120 to 130,000 patients a year. So higher volume, definitely rapid turnover of patients, and lots of problems with bottlenecking in terms of inpatients boarding in the emergency department and trying to find ways to improve throughput within the department despite that outward flow problem on the backside. So in this space, chief nurse had actually reached out and asked for some support. We found a leader who had a vast amount of experience taking care of patients in large volume EDs for a large number of years, as well as managing multiple departments outside of the emergency department. In the selection for this leader, I knew that I wanted somebody that I would find to be very much a relationship type leader. So somebody who would connect, grow future leaders, really work and partner with the hospital, not putting the emergency department on an island, but really partnering with the hospital to help improve throughput. That wasn't the focus. Inpatient throughput was not the focus for the ED project. However, we wanted somebody who would be a strong partner to inpatient leaders to help grow those relationships and improve that business that way. The leader started in March, and we had kind of a pretty big, broad kickoff our first week because this was a transitional leadership project. So again, transitional leadership projects with HealthLinx, those solutions have SMART goals. In this case, we are focused on door to bed, decreasing our triage times, door to doc times, all the standard ED metrics. As we were working with this hospital, we really realized that there was a lot of variability in who was doing what and how the roles were interacting. We found that there was an opportunity to improve communication on the shifts by implementing board rounds to make sure that we had both throughput as well as safety rounds in terms of keeping patients safe and making sure we were all on the same page about what the barriers were for that patient to successfully achieve their visit. So those board rounds were very successful with that. We also made sure that we had a very clear cut who's responsible for what. Is it in terms of contacting and having the conversations with patients who had left without being seen, who's responsible to close the loop on that and make sure that they are okay. We've followed up with them, they're doing well. So we assigned somebody to do that. We made sure that we are also checking and monitoring every 4 hours. How's our door to doctor times? How's our door to discharge times? How are we doing in terms of nurse leader visits for those patients in the department right now? Every 4 hours, we're looking at that along with our productivity to make sure that we're on track for all of our important metrics. Our team leaders are partnering with our assistant nurse managers to make sure that those things are happening. And we're making sure that we're closing the loop on anything that we see as a gap or an opportunity to correct that in the moment before the next 4 hours has gone by. And we found that from our leader started in March, we had an average year to date at that time, our door to bed time was 25 minutes. In April, we saw that increase to 27 minutes. And then we kicked off our project to really work on this decreasing this time frame, really implementing a three-way flow where patients, some of them were being directly bedded into the emergency department for those higher acuity beds. Some were going through a kind of a vertical flow for those higher acuity patients that really didn't necessarily need a bed but needed care sooner. And then we had more of your traditional fast track space. As a result of those areas being kicked off and really implemented in a significant new way, in May, we saw that our door to bed time was 14 minutes. And actually by June, we were down to 6 minutes from arrival to bed. We found then that our door to doc times, likewise, in March, we were at 29 minutes, and by June, we were down actually to 17 minutes with a goal of 20 minutes. So by the time patients walked in the door, within 17 minutes, they were seeing a doctor. Absolutely amazing progress for this very high busy ER. Our discharge length of stay for these patients that were being seen quicker, as you can imagine, we went from, in April, 201 minutes, all the way down to 177 minutes in June. So a significant decrease in the amount of time patients were having to spend in the emergency department, which then decreases the amount of volume of people sitting and waiting for things to happen. We have seen our left without being seen stay pretty stable. It's not where we would like to have it yet, but we are down below 2%. So we're happy with that. That is actually very, very impressive. In this state, there is a requirement for offloading EMS within a certain time frame, and that's publicly reported, as it is in many states. In the state where we were doing this work, EMS actually can put the hospital on bypass or divert, if you will, if you achieve or if you exceed the offload times that are expected by EMS. We were seeing that in March and April, as our leader was just starting the work, this time actually peaked in April to 20 hours of EMS imposed bypass happening every month in April because of the offload times. Our leader quickly saw that as a problem. We put in place an immediate process to improve that. And in May, we had 1 hour of bypass imposed by EMS, and in June, 0 hours. We have our offload times consistently reduced and back to a reasonable amount that is actually sustainable for future state. As a result of this, our patient experience scores have also improved. In this department, we now have, as of the end of August, our patient experience scores, likelihood to recommend, are at 82% for the emergency department, starting out in the single digits for this hospital. Through doing this, we were able to improve that time because of the quicker time to see a doctor, as well as the decrease in the length of stay overall.